Good evening and welcome to the Recall Medical Educational Series. I am Helen Reeve-Stouffer, the Chief Clinical Officer for Recall Medical, and it is my absolute pleasure to welcome you to the next installment of the series Perspectives on Building an International Hypertension Management Program. Thank you for your patience. We experienced a few technical difficulties with getting cameras and audio on, so I think we should be good now. So each of these educational programs is designed so that you can listen to experts sharing their unique perspective on how to build a hypertension management program, as well as why they have considered the Paradise Ultrasound Renal Denervation system as an integral part of the continuum of their patient care. And today on our program, we're joined by an esteemed care team from Collider Health in Buffalo, New York. Our three experts will discuss how and why they brought the Paradise system to their institution. You'll also learn about the safety and efficacy data generated from the RADIANCE Clinical Trial Program and how that influenced their decisions to consider using the ultrasound renal denervation treatment as an option for their patients with uncontrolled hypertension. So I look forward to being able to introduce our speakers and hearing their input on this very important topic of bringing a new hypertension platform to a regional health center. So these are the program disclosures. It's fully sponsored by Recall Medical Incorporated. It's intended to discuss topics of hypertension and renal denervation that are consistent with the FDA-approved labeling for Recall Paradise Ultrasound Renal Denervation System, and CME credit is not provided. So it's my pleasure to introduce our three panelists today from Collider Health in Buffalo, New York. So firstly, we have Dr. Vijay Iyer, and Dr. Iyer is the Chief of the Cardiovascular Service Line at Collider Health and also Chief of Cardiovascular Medicine at the Jacobs Institute of Medicine and Biomedical Sciences. So welcome, Dr. Iyer.
Thank you.
We also have Adele Whitted. Adele is a board-certified family nurse practitioner. She's worked in cardiology in Buffalo, New York for over 10 years, and she currently works in the inpatient acute setting as well as the outpatient setting treating cardiac patients. She's the lead advanced practice provider for the Renal Denervation Program in Collider Health, and she plans to become a certified hypertension clinician in August of this year. So welcome, Adele.
Thank you so much.
And last but definitely not least, I'd also like to introduce Julie Juzdowski, the Director of Peri-Procedural Services at Collider Health in Buffalo, New York. Julie's experience includes both inpatient and outpatient services. She has 11 years with neurosurgery, as well as 6 years of experience in cardiology. So welcome, Julie. And perhaps you'd like to state your final last name correctly.
You did just fine. Thank you.
Thank you. And here are the disclosures for the presenters. So in today's conversation, we're going to discuss the journey that this team have traveled in order to establish an interventional hypertension program. So it'll be from both the physician, from the advanced practice provider, and the administrative perspective. We're going to hear about the clinical data and the technology for the Paradise Ultrasound Renal Denervation System and why they chose the Ultrasound Renal Denervation System, how they started the program, who was part of that process, what information they shared and with whom, and some of the steps that they've been taking along this journey. Also, we'll be discussing, and I'm interested to hear this very much from Dr. Iyer, what they believe the appropriate patients for this treatment to be at this point in the journey with the Paradise system. And hopefully, if we have time, they'll be able to share a few examples of patients that have actually been treated with the Paradise technology at their institution. We'll talk a little bit about the patient's journey as well. So what happened up to the procedure, what made the patient a good candidate for the procedure, the procedural workup, technology, and post-procedural journey as well. And we will have time for questions at the end. So if people have questions, please feel free to place them in the Q&A chat. We will interrupt the discussion if needed, or we will just use the end of the discussion for the questions. So very quickly, before I turn the program over to our three panelists, I just want to discuss the key milestones that have occurred in the history of the Paradise Ultrasound Renal Denervation system. So everything from the early development of the technology through to the most recent FDA approval. So just for some history for those that are not quite so familiar with the Paradise system and with Recall Medical, the development of the technology actually started way back in 2009. In 2009, the technology was developed and the early first-in-man studies were initiated in South Africa and also in France. The system received its CE mark in 2012, and after the conclusion of the early studies, the RADIANCE program began. And the RADIANCE program was developed in collaboration with the FDA and in line with the requirements of the societies that collaborated with FDA after the failure of the Simplicity HTN-3 trial. So 2015 was the initiation of RADIANCE HTN. In 2018, the RADIANCE HTN solo off-med trial met its primary endpoint, and that was presented and published. In 2021, the RADIANCE HTN trio on-med trial, so that was a trial where patients were stabilized on a triple medication. If they remained uncontrolled, they were then randomized to treatment or sham. It met its primary endpoint and was presented and published. And then in 2022, the RADIANCE 2 pivotal trial met its primary endpoint. And these three trials were basically the basis of the PMA submission that was made to FDA, concluding in the FDA approval on November the 7th, post-FDA panel. And importantly, so this is the announcement of the approval of the system straight after the February 7th PMA approval by FDA. And importantly, I think it is to just pause a moment and look at the indications for use that were approved by the FDA. So the Paradise system is indicated to reduce blood pressure as an adjunctive treatment in hypertension patients in whom lifestyle modifications and antihypertensive medications do not adequately control blood pressure. So I think this importantly demonstrates that at this point in time, the FDA does not consider renal denervation to be a first-line therapy. And I'm interested to hear later on in the discussion from Dr. Iyer who he believes the appropriate patients are for this technology as we move through its journey from approval through commercialization. Importantly, of course, I'd like to document the contraindications for the device, mainly due to anatomical exclusions, as well as the safety profile, which is here from the IFU. And Dr. Iyer will also give us more detailed information regarding safety during his presentation of the clinical safety and efficacy data. So I'd like to now hand the presentation over to Dr. Iyer to get his perspectives on both the technology and the clinical data. So Dr. Iyer, maybe you could describe for the audience what impressed you about the Paradise technology.
Sounds good. Thank you so much, Helen. I appreciate the opportunity to share our experience, but also talk a little bit about this absolutely exciting technology as we start and embark on this pathway here in the United States. Paradise Ultrasound System really is an ultrasound-based modality which delivers quick and uniform delivery into the perivascular tissues. It generates a 360 degrees zone of ultrasound therapy, creating a circumferential energy emission to maximize coverage of renal nerves. As most of the audience probably knows, the renal nerves run in parallel to the renal arteries and are thought to mediate the hypertensive response, more so in patients who are refractory hypertension. But we'll talk a little bit more about, appropriate choices of patient care for these patients. These nerves are devoid of Schwann cells, and therefore, once ablated, do not have the capability to regenerate. There is a hydrocooling system built into the renal ultrasound Paradise system, which allows and prevents the heating up of tissue. The luminal cooling minimizes thermal injury to the vessel wall, so minimizes any damage to the endothelium of the renal artery or to any of the other tissues, while very selectively targeting the renal nerves. We go to the next slide, please. Okay. The ultrasound renal denervation system, in a very short period of time, in about a 7-second sonication, delivers energy up to 6 millimeters depth in a 360-degree range. So it really covers all the nerves that are running in parallel or around the renal arteries, and provides a very good coverage of these vessels, giving rise to up to 80% denervation, as we will see in subsequent slides. So as you can see with the simulation, this energy that is generated from this, from the core of this balloon, as it is occluding the vessels, generates within 7 seconds an energy which provides sonication and doesn't do any damage to the endothelium, as the safety profile will subsequently demonstrate. Why is 360-degree sonication important? Because as we move from the proximal vessel to the distal vessel, we will see that the distribution of nerves does tend to change. And as a consequence, when you are in 80% of the renal nerves, which are targeted in that proximal portion of the renal artery, in that 360 circumferential sonication, it really gives you adequate coverage and adequate denervation of most of the vessels as they traverse that space and travel towards the renal into the kidneys. The contact energy source and the fact that there's a hydrocooling system which is inbuilt, and the simplicity of the system is that it's a single hookup system where we don't have a lot of wires and tubes running into the system, allows you to do this procedure in a very simplified fashion with no concerns for thermal damage to the intima of the blood vessel. If it's okay, if there are no further questions on the actual system, can we, we're going to transition to the clinical data on what makes us excited about the therapy and where is the clinical data and what led the FDA to approve this therapy, giving us some very useful tools to treat some of these patients who are rampant in our practice. The RADIANCE trial designs of the 3 trials, SOLO, RADIANCE 2, and TRIO, included 2 trials, SOLO and RADIANCE 2, which were in moderate hypertension patients, and TRIO, which was really more in sort of a refractory hypertension patient population. The chart, as you can read, shows you in SOLO the patient population which was selected in this trial. These are patients between the ages of 18 and 75. Their office blood pressures were elevated on at least 2 medications or controlled on 1 to 2 medications. They all had GFRs of more than 40. There was an antihypertension washout period followed by enrollment in the trial, and the ambulatory blood pressure monitoring criteria at baseline needed an ambulatory blood pressure in daytime greater than 135/85 and 170, but less than 170/105. RADIANCE 2 was a similar sort of a trial which had very similar inclusion criteria with an antihypertension washout and similar AB ambulatory blood pressure monitoring criteria. All of these patients had CTAs, MRAs, renal Dopplers, or renal angiography to exclude renal artery stenosis. All of them had the ability to, we had obviously all of these patients were excluded for secondary hypertension causes before they were enrolled in this trial. TRIO was a trial that actually looked at patients who were on multiple medications, 3 antihypertensive meds, again, no renal dysfunction. They had a fixed dose 3-drug combination plus stimulation. So these were patients who were truly refractory on 3 meds. So this is a population that we see a lot of in the current practice, And at least in our initial experience, this has been the patient population that has ended up getting treated the most in our institution. So all of these patients, no med changes unless there was escape blood pressure criteria exceeded. And all of these patients were followed by the physicians and outpatient assessors who were blinded at randomization. And I think the blinding is extremely important for these trials because we all know that there is a significant amount of randomization bias in these patients. And the trial basically showed that in the mild to moderate hypertension population, both the solo off-med and the RADIANCE off-med population, there was a substantial reduction in the ultrasound renal denervation group when compared to the sham procedure group. And you can see that all of these were statistically significant. Similarly, in the resistant hypertension patient population, we saw a statistically significant reduction in blood pressure. The median blood pressure reductions were of the tune of the difference between the sham group and the treated group was about 6.3 in solo off med, similar in RADIANCE 2, and a little bit lower in TRIO, about 4.5. Not only was this a short-term result, we also saw that there was a consistent ambulatory home and office systolic blood pressure reduction in the individual pool data analysis. You saw a substantial reduction in the daytime ambulatory systolic blood pressure in the ultrasound renal denervation group. The nighttime ambulatory systolic blood pressure was also substantially reduced and statistically significant, as were the 24-hour ambulatory blood pressure, home systolic blood pressure, and the office systolic blood pressure. So across the board, it didn't matter what parameter you tested, we saw reductions in the blood pressure in this population. And the office systolic blood pressure, which often tends to be the most commonly used clinical metric that is followed by physicians to titrate medical therapy for blood pressure control, showed a huge 10 millimeter reduction in the renal denervation arm, and obviously was statistically significant compared to the sham treatment arm.
And Dr. Iyer, maybe I could just ask you what you consider the minus 10 millimeters in office to reflect from a cardiovascular risk reduction perspective.
I think we all know, and we'll talk a little bit about that, small reductions in blood pressure. When you think about some of the antihypertensive medications that we use, and you look at the trials that demonstrated significant benefits, not only in the reduction of blood pressure, but also long-term outcomes, the magnitude of the reductions are of the tune of 3 to 4 millimeters of mercury in some of those trials. So a 10 millimeter reduction in blood pressure equates to a huge reduction in overall cardiovascular mortality, and that includes stroke, heart failure, and MI mortality over a long period of time, especially as this next slide is going to show you. Not only is this a short-term result, it appears to be sustained out to 36 months in RADIANCE hypertension solo and in the RADIANCE hypertension trio. The reduction of office blood pressure by a 10 millimeter mercury equates to approximately a 20% reduction in risk of cardiovascular events. When you put that in the context of population health, that is a huge benefit to our population. And if you translate it into economic terms, that is a huge cost savings to the healthcare system from that reduction in blood pressure. So I think we tend to look at these numbers, and often if you don't link it to what the implications are for that kind of reduction in blood pressure for the long-term outcomes of this population, it is easy to be underwhelmed by just the numbers, but to really look at the magnitude of reduction, you start to see what a huge impact this kind of therapy is going to have on the population as a whole. When we look at the safety profile of this therapy, you'll see that the ultrasound renal denervation had very low mortality and virtually no complications related to the procedure. Very importantly, if you look at 6 months, there was no suggestion of any endothelial damage leading to renal artery stenosis in the renal denervation arm, suggesting that this is a very, very safe therapy. And that is extremely important when you consider that you are going to be offering a procedure to patients who are otherwise only taking medications, which has obviously a relatively low, good safety profile, though they do have their own side effects for a lot of these patients as well.
Thank you. So maybe as we transition, we can talk through how you brought the ultrasound renal denervation to the Collider Health system. So maybe you could talk through some of the key aspects as to why you would bring such a therapy into your institution.
I think when you, let's take a step back into the data that we looked at. If you look at, on an average, the number of patients in our practices who have adequate blood pressure control or excellent blood pressure control, the numbers in the literature are variable, but I would suggest that less than 50% of the patient population that we see in our practices are truly excellently controlled when it comes to their blood pressure. Many of them are on multiple medical therapy. Many of them have issues with compliance. And when you think about the magnitude of that problem of poor control and what the long-term outcomes are as a consequence, it is extremely important to have therapeutic options for these patients so you can truly think about it in the context of population health and say, what can we do to reduce the long-term outcomes? We live in Western New York where we, despite being in the Northeast, we think of our mortality numbers or our morbidity numbers related to events like myocardial infarction and stroke, similar to some of the southern states in the United States where the incidence of hypertension and hypertension-related complications are pretty high. So for us in the Western New York area, we felt as a community, as the leader in healthcare in this community, we needed to provide this therapy to our patients. There was no question that this is extremely attractive technology. It is clearly beneficial. It clearly is going to make a huge impact in the long-term health of our population. So as leaders in this area in the Western New York community, we felt it was imperative that we bring this therapy to our patients.
And I'm assuming that the whole process in terms of choosing the patients, and I know we'll talk more about the profile of the patients that you think are most appropriate, but do you look at this as a collaborative decision-making process, including the patient in that journey towards renal denervation treatment?
I think it's absolutely critical to think about this in the context of hypertension management and not just a procedure that is offered to patients. Renal denervation can be seen as a continuation of drug therapy, lifestyle modification, and all the other therapies that we are utilizing now for adequate blood pressure control. It cannot be seen as a standalone procedure. It is not, as I think about it, as not a institution trolling for procedures to do, which is potentially what some people may look at it as. This is really in the continuum of care of these patients for whom medical therapy, lifestyle modification, and all the other things that we attempt to do, all the secondary causes like sleep apnea therapy, etc. When all of those have not worked and we continue to have these patients who are interested in getting a handle on their blood pressure and get a better control, this is very attractive therapy.
I think that's incredibly important because you're looking at it as a piece of your hypertension management program, and that's very much in line with the indication that FDA approved for the device. So thank you. So we've spent some time discussing both the technology and the data. So I think now is probably a good time to walk through some of the more practical aspects of actually bringing this type of technology into the cath lab, and I think the process is probably similar, independent of what the new service line would be. So I think, Julie, can we start with you as the director of the cath lab services? Can you walk us through the process for this technology, but also for any new service line as you bring it to the cath lab from an administrative perspective?
Sure. First, it starts with physician interest, like Dr. Iyer said. They bring it to our attention. We then meet with the company, view the contract for the services. We work with purchasing for the products that are required that we'll need to bring in. We review reimbursement and work with the hospital and RECOR's Director of Market Access to make sure that we are looking at the complete reimbursement that we will receive. We work with finance and build a pro forma, for which then we review the contract and pro forma with our administrative support. the administrators of the hospital to gain their support. While doing this, we're also working on a marketing plan. We're working on refers and outreach, prior authorization protocols. It's very important for the patient selection, the provider documentation for the insurances for approvals. If denied, it's important to ask if an exception can be made. The patient also has the right to appeal a denial. After that, we work on identifying patients. We finalize the contracts and coordinate physician and staff training, and then we started our cases. And that's primarily what we did to start the program.
So it sounds like having a champion such as Dr. Iyer is crucial to the success of this type of program, bringing it into the cath lab. Would you agree with that?
100%. It won't go any further if you don't have his support.
And are there tools that you have been provided with from RECOR or outside of RECOR that have helped you through the process, either with the patient screening or with the other steps that you've had to step through?
RECOR has been amazing. They've been through this every step of the way with us. They've helped us reach out to the referring providers. They've helped us work with the insurance carriers. We worked on prior authorizations. They're helping us with our reimbursements now, still trying to help with anything they can.
Great, thank you. And I believe there is actually a patient screening form that can be provided to the institutes that may help both with the identification of the appropriate patients, plus also with the reimbursement issue. So I think that can be provided to any members of the audience after the presentation. So as we continue kind of thinking about the bringing of ultrasound renal denervation into your institute, maybe you can talk a little bit more about the administrative process and from an administrative perspective, what made the Paradise system a good fit for your institution. Maybe Dr. Iyer, you could address that.
Yeah, I think, when we talk about any procedure or any sort of a service being brought into a hospital system, the most important thing I think about as a physician leader is this therapy efficacious and is it safe? I think that's the first step in value, right? For a physician, value comes, the dollars are an important part of the health system, but from a physician-patient relationship, if we cannot establish efficacy and safety, I think you sort of don't go beyond that step. For us, this was a therapy that was clearly efficacious and very safe based upon the data. The second part of it was it fit a huge need for our community. And the last part of it is that we felt that we had partners with industry who were willing to work with us, given the challenges that do exist at this point in this therapy with reimbursement and all the other factors that go in. Lastly, when you look at it, the procedure as in its totality, and you say, how much of a burden does it add to the system to start providing additional therapy? How much staff training is going to be required? How much cath lab time is going to be required? How are we going to accommodate this patient pool and patient population? How complicated is it going to be to screen? Is the cost associated with bringing this therapy far greater than the benefits that we may be able to provide to our community? On all of those accounts, we felt that these were positives for the health system at this point, despite the lack of reimbursement. So I think what we feel and what I think is an important part, at least at this stage in the therapy, is that we were able to bring a therapy in that is relatively easy to administer. It's easy to train your staff in. It's a procedure that does not take a lot of resources from the health system. This is a short procedure. You don't have a lot of cath lab time requirement. There's not a lot of inpatient stay. So when you put all of that together, this is very attractive therapy, and the potential payoff, both in terms of the patient benefit long-term, the population health benefit long-term, and hopefully eventually to the health system, even a possible financial payoff. This we felt was a win-win for us.
And you mentioned, obviously, that we're early in the reimbursement journey with renal denervation. Are there any tricks or tips that you can provide to the audience that might help them get through some of the reimbursement challenges or hurdles that they have at their own institutions?
I think, with many, many new therapies, and you can go back in time, the last 10 years, all the new therapies that have emerged, whether it be transcatheter valve replacement or left atrial appendage occlusion, uh, just because of the way our systems are built within healthcare, most processes and procedures and devices often get approved much before reimbursement comes around. And I think there is good reason to believe that given the efficacy of the therapy, CMS will come forward with the appropriate CPT codes and the reimbursement. But as a health system, we felt that we couldn't wait for that to catch up. We needed to be up at the forefront of providing this technology. We are cautious in who we provide it to. We are cautious in how many cases we do, but we didn't feel like we could wait in this process to be much later. Are there any obvious sticks and trips? I think the most important process here that you have to do as physicians, or if you're physician champions wanting to bring this in, is to have an honest conversation with your administration about what are the goals of what you're trying to do with this therapy. Why is it important that you bring it into your health system or for your patients, and come to some sort of an agreement on what you can realistically accomplish in an environment and a market where you are probably not going to get a lot of reimbursement in the initial phases. And obviously enter into an honest conversation with RECOR as to how can they help you build the program in its initial phases, understanding completely all the challenges with reimbursement.
Thank you. It sounds like the partnership is very key. I mean, in the understanding of time here, I think it's probably important to move on and talk about growing a renal denervation program and how you see that happening in the future. One of the questions I get asked a lot is who are the right patients to treat at this point, and then how do you find them? So what are the right referral pathways? Are there specific referral pathways? Are there multiple referral pathways? And how do you inform and educate those referral physicians that this therapy is now an option for patients with uncontrolled blood pressure? So maybe, Adele, we can pass it to you and you can walk us through what you've done in the Collider Health System to create the program and the referral processes.
Sure, thank you so much for having me. So we're extremely fortunate within the Collider system that we have a very large pool of not only patients, but providers. So one of the key things that we've undertaken is trying to educate our providers, not only on the procedure, but who would be the ideal patients for this. One of the tools that we have at our disposal is the screening referral sheet that RECOR actually provides. It's extremely simple to use. It's very clear on exactly, who at this point in time would be our ideal patients. So we've been working to get that out to the community, not only to our providers, but as well as other cardiology practices. We've had one physician that has undertaken some luncheons to go and speak to the other cardiology practices. So we're hopeful that as patients hear about it from other, from their cardiologists, they come to us and say, I heard about this procedure. Patients can be their own champions, and we've seen that already in patients even self-referring.
So it sounds like you have a pretty holistic way of looking at the program. And do you have a marketing department that you work with in the Collider Health System that supports you?
We do, yes. Collider has a marketing department for sure, and they've done a great job. We have internal emails that go out, once a week and monthly. They can highlight new procedures and who to contact in order to sort of refer their patients as well. Collider is a huge sponsor within the area as well. So people look to us, as Dr. Iyer was saying, as a leader in healthcare.
So is there anything else that you would like to pass on to the audience regarding the community side of referrals?
Yeah, I think the most important thing is to educate, the providers that are looking to refer these patients. I think that the communication between the provider and the patient is so important. I think that when you say numbers, as Dr. Iyer spoke to earlier, 4 to 10, points, it doesn't sound like a lot to people, but when you frame it in the context of if you can reduce a blood pressure by 10 points, you can reduce your risk of 20%. I think that really resonates so much more with patients and the providers. So setting those realistic goals and making sure that you're trying to select patients that are appropriate, that have had their secondary causes, already ruled out, that are making those lifestyle changes, that really either have, sometimes very many medication intolerances, significant side effects and you're really starting to become limited and adding additional medications, and you're just not getting those patients to the goal where they need to be. So we're trying to selectively, choose our patients, while also opening it up to the greater community, so that way we can at least begin this conversation about what it is we are looking for.
I think that's really important. And I think that's actually kind of a perfect segue to talk a little bit about some of the team members that are involved in this process with you. So Adele, maybe you could specifically discuss your own role as the advanced practice provider, and then maybe other team members that are essential in making this program successful.
Sure. Obviously, this team would be nothing without Dr. Iyer and Julie. So they are the champions for sure. So Dr. Iyer and I work together to help select the patients. So I will receive a referral either from within our practice or outside, and I undertake a chart review to see, what secondary screening tests they've already had. I review their medications. I set up I try to do a lot of telehealth appointments. I think that it makes it a lot easier for patients. Many of these patients have other specialists. They're constantly running around. So utilizing telehealth, I think, has been really vital. And so then I pretty much do the chart workup, the prep. I see the patient, and then, I work with we have a dedicated surgical scheduler. So she helps me get the patient scheduled. We have a prior authorization team. So I'm hopeful that as the program continues to grow, we can add, a dedicated registered nurse, a medical assistant as well, to sort of help do the preparation and, the fielding of the referrals.
Are there tools that you find resonate well with the patients when you're describing this option to them?
Yeah, I mean, Recore, the website itself is fantastic. So I have a lot of printed materials. And if I'm utilizing, obviously, a telehealth encounter, I always refer to the Recore website, because it's great, and it's nice to have something that you can also look at. And then a lot of these patients want to talk to their families about it. So the website itself has been fantastic. And again, the screening tool, I think, is also helpful. And I go over that with them. Here's why I think you're a great candidate for this.
And are there other tools that you're either using now, you may use in the future, which you think would help you find appropriate patients? I know there's been some discussion about using AI technologies for EMR searches. Are those type of tools available to you or useful to you?
I would have Julie speak more to the AI technology, because I know that's up and coming. So.
Yeah, we have, we're working with a company now that is going to scrub our patient records throughout the hospital system, and will pull out the patients in a list for us, for which we can screen them, and then reach out to the primary care physician or cardiologist to see if they would want to refer them for renal denervation to our group.
So it sounds like you've got some tools in the future. Sorry, Dr. Iyer, please continue.
No, I think it's important for physicians to recognize that as we transition into the world of value-based care, it is not going to be out of the question for both for the payers to be asking questions like, in your panel of patients with hypertension, how many of them are adequately controlled? So we are all going to need to develop tools to have a very clear understanding of the patient panels that we have, how many of them have difficult to control blood pressure, how many of them are adequately controlled. And using these AI-based tools is not only a builder for renal denervation, ultrasound-based renal denervation, but it is an essential quality metric that tells you how well your practice is doing on this key concept. And I think this is important for us to look at, not just in the context of the fact that you're screening patients for a procedure, but really getting an understanding of how well are we doing as a practice or as a healthcare system in controlling what is an essential marker for long-term cardiovascular morbidity and mortality, which is hypertension.
I think that's incredibly important. Yeah, I think that's a very good point to be made. And I know that there are other programs across the country which are doing the same thing. So thank you. So Adele, did you have any additional information that you wanted to share with the audience about starting up the program in Collider?
Sure. So, I work as an inpatient APP 2 days a week, and then in the outpatient setting also. So, the great thing about this program thus far is it has been very manageable for me to add on to my current, workload, which has been fantastic. I mean, so many of these patients I'm already seeing on the weekly basis. Their blood pressure is difficult to control. They have multiple risk factors that are dependent on controlling their blood pressure adequately. So I suspect that as the program continues to grow, getting those additional employees on board will be extremely helpful. But I've been doing this now for several months, and it's been great to see the patient outcomes. And thus far, it's been extremely manageable.
I think that's a perfect transition to actually talk about the patients. So because we're moving on in time, I think it might be a good idea to move on to talking about the patient care pathway and who is the appropriate patient for treatment at this moment. So Dr. Iyer, you've had the opportunity to treat a few patients now. Perhaps you could spend a few minutes just discussing who you think is the appropriate patient, and then if you're okay to share a couple of case studies, I'm sure that would be very valuable to the audience.
Sure. As we start the program, one of the key things for us to make certain that we were picking patients who were appropriate clinically, but also motivated. We really wanted patients who wanted an opportunity to have a better handle on controlling their blood pressure. So many of the patients that we have seen are truly engaged in their care and want to reduce their blood pressure. They have tried everything. They're compliant with the medical therapy. They have truly attempted to either lose weight or manage their sleep apnea. So it's important because not just is it important for the patients to be motivated, but also from a healthcare system. And in terms of looking at a procedure and advertising it to internally and externally, we want to have some early successes. So we've taken patients who truly have elevated blood pressures, who've been adequately treated medically and continue to have difficulty to control blood pressure. So that has been one of our strategies, at least early on, just in terms of how we are starting this program. I'd like to share a couple of cases. I think Adele said this well. One of the things she very carefully looks at in the secondary screening is to make certain that every secondary cause has been truly excluded, and some of the hidden ones like sleep apnea have also been taken into account. We also have to be realistic. We have had some, what I would say are maybe not so appropriate referrals of morbidly obese patients with difficult to control blood pressure. I think we've felt that those may not be adequate targets at this time, or referral patients who are an end-stage renal disease, which currently is not an approved indication. So we have to sort of be very careful in who we treat and how we screen these patients. So what Adele does is critical. It is not only important that we get the procedures done, but we have to do it in the right patients and obviously with a very good safety profile. So here's the first case. We have a 53-year-old male who's hypertension, obese, is on sleep, who's got sleep apnea, but treated adequately on CPAP, hyperlipidemia, non-obstructive CAD, currently on amlodipine, carvedilol, hydrochlorothiazide, and losartan, and continues to have elevated blood pressure. So this is truly sort of your trio kind of a patient, and maybe even more, and has had really difficult to control blood pressure. This patient is very compliant with medical therapy. He's been hypertensive since the age of 33, very concerned about his inability to control blood pressure goals, despite good compliance and every attempt to manage his lifestyle. This patient was a referral from a primary cardiologist. Adele did a very detailed chart review, had a conversation with the patient about the benefits, the potential risks, and why the patient is or is not a good candidate for this therapy. After all of this was done, I think one of the key things, and Adele will agree, is that it is important to set realistic expectations for these patients. Some people come in expecting that they're going to come off all their meds. And I think it's important to recognize and teach not just the patients, but also the referring providers that this therapy is most likely going to get better control on current medical therapy. Some patients may be able to come off one of their meds, but many of these patients will continue to need to do all the other lifestyle modifications that are recommended in the guidelines to maintain their blood pressure at adequate levels. Procedurally, I think this procedure is very simple. Any interventional cardiologist can do this procedure. It's groin axis. We always use ultrasound and micropuncture because, again, this is an elective procedure. Our tolerance for any complications is extremely low. It requires a 7-French sheath and a 7-French guiding catheter. The two guides we use most commonly are an IMA guide or an RDC guide. We typically do a non-selective abdominal aerogram with a 5-French pigtail, identify the renal arteries, make sure that there are no unusual anomalies that we have not previously recognized in the secondary screening. Usually we use a standard 014 wire. I've used a run-through wire in most of these cases. So do most of my partners. We do a qualitative angiography, and in some cases, we've done intravascular ultrasound for balloon sizing. We don't typically get a CT on every patient. If you have a CT, that's great. And then we go on to do ultrasound renal denervation as per the protocol. So meaning based upon the size of the vessel, we do sonications on both sides, making sure we do 2 to 3 treatments on each side. If there are accessory renal arteries that are greater than 3.5 millimeters in size but less than 8, those are also treated. So that is a standard protocol. Typical procedure time is between 30 and 45 minutes. Patients go home the same day. These are some illustrated pictures of renal angiograms and the ultrasound pictures. Again, sonication location. In this case, just let me go back to the last slide. This is a case where you can see vessel size and vessel length. We typically stay very proximal in these vessels. We did 3 therapeutic sonications of the left renal artery in this case and 2 on the right side. Total procedure time was less than 45 minutes. The amount of sedation used was about 3 milligrams of Versed and 150 micrograms of fentanyl. These patients do feel the sonication at the time of the procedure, but it's extremely short. And when adequately sedated, they get through this procedure very, very safely without too much discomfort. This patient was followed up within 1 week and at 4 weeks post-procedure. Since the procedure date, documented blood pressures have been consistently less than 140/80. Post ultrasound denervation blood pressure at the 4-week interval was 170/70, 110/76. Most importantly, the patient was very satisfied post-procedure. Reports what he calls peace of mind because he is consistently seeing well-controlled blood pressures, both on his home measurements as well as his systolic blood pressure measurements in the office.
So can I just ask you?
Add to that. I was just going to say, I can add to that. The patient, was, as Dr. Iyer mentioned, extremely motivated. He continues to work on lifestyle modifications, and he actually did have the ability to come off one of his medications. He's been an extremely motivated patient, yeah.
That's a great success story to present. So thank you. I was just going to ask, and you talk about the post-procedure follow-up at 1 and 4 weeks. Is that your standard? So you would follow all your patients at 1 week and then 4 weeks? Do you continue to follow them, or are they passed back to their referring physician?
We continue to follow them virtually. We don't have them come into the office. We don't take over the care of these patients. The only reason we want to do at this point a very detailed follow-up is we want to have a very good understanding of who are the patients who are benefiting from this therapy. How well are we doing as an organization or as an institution in terms of the success of this program? So the 1-week follow-up is primarily to make sure that there are no procedure-related complications and the patients have a clear understanding of what the expectations are from them after the procedure. And the 4-week is really the first kind of checkpoint time in to see what is their blood pressure doing. Beyond that, we continue to keep tabs on their blood pressure through their physicians. We are, again, not trying to assume their care. They will all return back to their physicians, either their primary care physicians or to their cardiologists.
That's great. Thank you. So we're about 7 minutes from the end, and I want to make sure that there's time for questions. So maybe we can just summarize, maybe each of you can just summarize for us why you believe the ultrasound technology, the Paradise system, is a good option for your patients, and then we can turn to questions. Dr. Iyer, maybe you could start.
Yeah, I think it's critical to understand the role that hypertension plays in long-term cardiovascular mortality and morbidity. Ultrasound renal denervation is an additional tool to modify that and improve outcomes for our patients. It is a therapy that is safe, it is efficacious from a standpoint of a physician or a healthcare system. It's easy to administer and it's effective. The larger financial issues are yet to be sorted out, but I think for any healthcare system that is looking to improve the outcomes of the population, this is going to be an essential tool in the armamentarium.
Thank you. And Adele, from your perspective, anything to add?
Yeah, I think it's just another tool that we have to help treat our patients. I mean, we have the ability to impact an extremely high-risk population. And I think that any sort of reduction that we can give in that risk is beneficial not only to them, but to us as well.
Thank you. And Julie, from your perspective?
One of the things I've learned is even with the reimbursement not being what it should be yet, it's good to get the hospital's buy-in and support with this, because we started that with TAVR and Watchman too, and now we have the largest programs in Western New York. So sometimes it's worth it to take that little hit to grow the program.
That's great. Thank you. I think that the analogy with other programs that are, newer technologies is very important for people to understand that this is a journey and we're at the beginning of the journey. So we appreciate very much the support and impact that you're having for your patients. So we can turn it over to questions. Are there any Q&A questions that have been submitted?
Not at this point.
So there's a question about concerns about decline in GFR from renal denervation. Dr. Iyer, would you like to take that?
Yeah, I think both the trials and our own clinical experience do not support any evidence of decline in GFR. Obviously, you have to be a little bit careful about the use of contrast in these cases. We've even done a couple of patients who've had some marginal GFRs, and we have done very well in terms of being able to manage the contrast volume. We have not seen any changes in GFR, and we have had no concerns about it.
And I think I would add to that the clinical data from the RADIANCE program, which now is looking out past 3 years, has not seen any concerning changes in GFR from post-procedure. Are there any other questions? If not, then I will take it to thank the panelists. Thank you, Adele, Julie, Dr. Iyer. Really appreciate the discussion. I think this is very valuable information for other healthcare systems working out how to implement the ultrasound renal denervation Paradise system into their hypertension treatment program. And just as a reminder, the patient screening form is available, and that can be found after the presentation. It will be placed into the chat forum. And I believe that there will also be a poll, just getting people's input onto what other further educational programs might be of interest to the audience. So again, I really appreciate your time this evening. I think it was very valuable and insightful discussion, and I hope everybody has a very good evening. Thank you.
Thank you.
Thank you, Helen. I think there was one last question that I'll quickly answer. The question was, do you stop any antihypertensive meds? And the answer is no. We don't stop any of the meds. We make a decision on whether to stop any of the meds post-procedure at the 4-week point, depending upon the response to therapy.
Great, thank you.
Thank you, Helen. Thanks for the time. Thanks for the opportunity.
Thanks, everybody. Good evening.
Thank you so much.
Have a good evening.